everyone. My name is Katie Bullard, and I work here as an aide in the ICU. Through my time working in the unit, I became passionate about end-of-life care planning and improving quality of life for patients with chronic and/or serious illness after witnessing countless unfortunate events of patients and their families choosing painful and often futile treatment plans in the hopes of grasping to a few more weeks or months of life. As some of you may know, I work with Dr. Anker on an advanced care planning startup called Healthcare Linked, which I'll discuss further at the end of this presentation. The goal of this presentation is simply to discuss some misconceptions regarding end-of-life terms we commonly use in the ICU. One of the most commonly misinterpreted terms is a DNR status. This term is profoundly misunderstood by clinicians at all levels. One New York Times article profiled this misconception and included several interviews of internal medicine physicians that admitted that they tell all of their patients to state that they are a full code if they are ever admitted to the hospital, even if that's not the patient's true desire. The most important thing to remember about a DNR status is that it is not saying do not treat. It is simply stating that should the patient experience any kind of cardiac or respiratory arrest, they do not want clinicians to attempt to revive them. Patients may undergo aggressive treatment, including surgery, dialysis, ICU care, etc., while being a DNR. I think it's safe to say that we all know what comfort care looks like. Patients typically end up on comfort care in the hospital if they are unable to make it home on hospice or if they do not want to die at home for whatever reason. If you don't know who Atwal Gawande is, you should take some time to look him up. He's an incredibly brilliant surgeon who has written many powerful books on the problems and challenges of modern medicine. In his book, Being Mortal, Medicine and What Matters in the End, which I highly recommend you read, he discusses the importance of a goal, of not just a good death, but a good life, all the way until the very end. And my favorite quote from that book is this: "Death is the enemy, but the enemy has superior forces. Eventually it wins. And in a war that you cannot win, you do not want a general who fights to the point of total annihilation. You don't want Custer. You want Robert E. Lee, someone who knows how to fight for territory that can be won and how to surrender when it can't. Someone who understands that the damage is greatest if all you do is battle to the bitter end." I've saved palliative care for the end because it seems to be the most misconceived term and type of care, which makes sense because it's a relatively new medicine. In the late 1950s, Dr. Cecily Saunders first articulated her ideas about modern hospice care based on her careful observations of dying patients. She advocated that only an interdisciplinary team could relieve the total pain of a dying person in the context of his or her family, and the team concept is still at the core of palliative care. In 1974, Dr. Balfour Mont, a surgical oncologist, coined the term palliative care to avoid the negative connotations of the word hospice and introduced Dr. Saunders' innovations into academic teaching hospitals. He first demonstrated what it meant to provide holistic care for people with chronic or life-limiting diseases and their families who were experiencing physical, psychological, social, or spiritual distress. Clinical practice guidelines for quality palliative care were first released in 2004, expanding the focus of palliative care to include not just dying patients, but also patients diagnosed with life-limiting illness. In 2006, the American Board of Medical Specialties and the Accreditation Council for Graduate Medical Education recognized the subspecialty of hospice and palliative medicine, and in the same year, there were 57 palliative care medicine fellowship programs established with approximately 100 trainees. With palliative care taking its place in academic medicine, this new subspecialty will enable future generations of physicians to advance knowledge in the field and fulfill a promise to patients and their families that they will not be abandoned when our treatments become ineffective, and that at all times we will do what we can to relieve their suffering. So just some bullet points about palliative care. Fun fact, palliative care is a term derived from the Latin word palliare, which means to cloak. It focuses on providing patients with relief from the symptoms, pain, and stress of a serious illness, whatever their prognosis may be. Treatment is considered to be more therapeutic rather than having a curative intent, although it may be delivered along with curative treatment. Palliative care is not reserved solely for patients in end-of-life care. It's simply helping patients with serious illnesses live well. Palliative care is appropriate at any age and at any stage in a serious illness. It is not a withdrawal of care, but a redirection of care to best meet the patient's needs. I like this Venn diagram because it's a great depiction of what palliative care encompasses. Palliative care can be practiced in parallel with oncologists, cardiologists, nephrologists, or whatever specialty medicine is needed for the patient's primary disease. Palliative care specialists focus more on the quality of life and symptom management part of the care plan, while other specialists focus on the curing of the disease part of the care plan, all while keeping open communication with each other and the patient. There are 3 general ways that palliative care helps patients. 1, professional management of pain and other troubling symptoms such as nausea, delirium, insomnia, or shortness of breath. 2, helps the patient make difficult decisions when trying to align all the things modern medicine can do and make sure that those decisions are in line with their values and wishes and also in line with a realistic prognosis. 3, it helps the patients tie together the multiple silos and complexities of the healthcare system into a way that patients and their families can understand and navigate their way through. So you might be asking yourself now, what's the difference between palliative care and hospice? Hospice is similar, but also distinctly different. Hospice is a setting by one definition, you're no longer pursuing curative treatment because it's either too rigorous or it's worked for a while and it's now failing. And the prognosis is no matter what treatment or therapy is performed, the patient is going to die from their disease in the near future. So the focus shifts to being more at home and comfortable. It's not always carried out in the home setting, but that's typically preferred. Palliative care comes before hospice. The patient isn't necessarily dying yet at all and may even still be curative. So let's look at a case study of what ICU palliative care might look like. So Mr. Anderson is a 63-year-old male with a past medical history that includes hypertrophic cardiomyopathy, history of lung cancer, end-stage renal disease with chronic dialysis, congestive heart failure, and he's had multiple hospitalizations within the last 6 months. So the events of his hospitalization, he presents to the emergency department with hypotension and is complaining of progressive weakness and episodes of syncope that led to a fall at home. He's placed on a max dose of vasopressin and sent to the ICU for further care. Once he arrives in the ICU, a care conference takes place. So Mr. Anderson, his family, and the physician decide not to escalate current care and discuss their options moving forward. The patient and Mr. Anderson's family agree to a palliative care consult. So the following morning, a palliative care specialist comes by and the following topics are discussed. Pain and symptom management in addition to the current hospital treatment plan, clarification of communication regarding palliative care, planning for subsequent outpatient care, and discussion regarding unrealistic expectations in pursuit of ill-advised treatments. So the overall goals of palliative care access are to improve timely access to palliative care for appropriate patients, improve end-of-life care, improve patient and family satisfaction, reduce readmission to the hospital and ICU, reduce personal burdens of unwanted, unnecessary, and futile care, reduce financial and manpower costs, improve communication and coordination of care, and finally improve chronic disease management. Possible palliative care triggers could be multiple hospital admissions or ER visits, recurrent ICU visits, frequent infections such as aspiration pneumonia, advancing dementia or debility, if a patient's confined to a bed or chair over 50% of waking hours, if the patient doesn't want to return to the hospital, if they're receiving chronic home health care, or if the patient's very limited in the care they can provide themselves. So finally, I just wanted to mention Healthcare Linked. It's the startup company that Dr. Anker and his colleague Dr. Chris Lamel co-founded. I've been volunteering my time since the fall of 2014 and have gained invaluable experience in working with patients making these difficult decisions. And I've even been working on Oregon legislature to improve Oregon's advanced directive system. This program has great potential to solve many problems facing today's advanced care planning framework. So I encourage all of you to check out the website at healthcarelinked.co and provide any feedback you may have to Dr. Anker or myself. We would greatly appreciate it. Thanks for listening. I hope that you learned something today.